Okay, hello everybody. Welcome to Pediatric Grand Rounds. I'm going to hand things off to Dr. Emily Burrito, who is going to introduce our speaker for today.
Hi everybody, welcome to Grand Rounds today. It is my distinct honor to introduce our speaker today. Dr. Pat Hammetz received her MD from Columbia in New York and her MPH from the School of Public Health there as well. She completed her pediatric residency and chief residency at New York Presbyterian Morgan Stanley Children's Hospital, and then worked as an academic general pediatrician there. During that time, I had the distinct pleasure of working with her clinically and as a research mentor in my early work in community pediatrics and how evidence can really inform the policies we make for how we do pediatric care and set up the system to try to take care of kids and others well. So it's really an honor to reconnect with her here. After practicing at Morgan Stanley as a general pediatrician, she was founder and director of their pediatric hospital medicine program, starting in 2007 through 2016. She joined the faculty at Children's Hospital Montefiore at Einstein School of Medicine in 2016 as the chief of the Division of Pediatric Hospital Medicine, as well as the senior medical director there. And today she's going to share her institution's experience during COVID-19 and transforming her children's hospital into a hospital that took care of, I think, a broader general New York population who needed help during COVID. Dr. Hammetz, thanks so much for being here with us today.
So thank you very much for that lovely introduction. It's really wonderful to see an old friend. I'm going to share my screen. Okay, there we go. I hope we're good. Okay, so thank you so much for inviting me to come and talk and to share a little bit about our experience with COVID in the spring of 2020. I have no disclosures. And my objectives for today are really to hope that you learn different models of expanding surge capacity within a children's hospital in a pandemic, to identify challenges for pediatric staff to meeting the healthcare needs of adult patients during the pandemic, and to understand the factors associated with our successful transformation of a pediatric inpatient unit into an adult COVID-19 unit. So unfortunately, I think this slide probably is not necessary at this point, but as way of introduction, severe acute respiratory syndrome coronavirus 2 or SARS-CoV-2 was first identified in January of 2020 after a cluster of patients with severe pneumonia presented in Wuhan, China in the months previous. The first case of COVID was diagnosed in New York on March 1st, and by March 11th, the WHO had declared it a global pandemic. By the end of March, there were more than 75,000 known cases in New York State and more than 40,000 in New York City. And as you all probably remember, at that point, testing was not widely available, so I'm sure those are gross underestimates of the actual prevalence of disease at that point. For those of you who are not from the East Coast, this is New York State. We are in the Bronx in New York City, which is down here. And this is, I'm gonna focus on the Bronx where we are, and this is New York City. The Bronx is kind of this tan color, I hope you can see my pointer, borough, the northernmost borough in New York City. The Bronx has a population of about 1.4 million people. It's a very diverse community with 44% are Black or African American, 56% self-identify Hispanic or Latino, only 9% are non-Hispanic white. And we are the third most densely populated county in the state. So of the 5 boroughs that comprise New York City, as I showed, the Bronx was hit particularly hard. And you can see the Bronx is the dark blue lines. The top graph shows the cumulative rate of known COVID infections per 100,000. And this graph goes through May 9th of 2020, which is when we really started to see things level off and stabilize and really be over the peak, excuse me. We had 2,869 reported cases per 100,000 in the Bronx. And the bottom graph is the mortality, which we had 285 per 100,000 was the mortality rate in the Bronx. And you can see on both graphs, the Bronx is the highest line of all of the New York City boroughs. So why was the surge so bad in the Bronx? And again, I hope you can see this. The Bronx is up here, the darker colors, and this is a heat map. So the darker color indicates the highest, higher prevalence. There were probably several factors that accounted for this. And I'm just going to go through a couple of them quickly. First, the Bronx has a disproportionate number of service workers live here. Those who we also have been referring to as essential workers, the people who drive the buses, work at the grocery stores, and clean the buildings. They could not shelter at home during the pandemic. They went to work and they were interfacing with others. So they really could not socially distance easily, thus making them more susceptible to getting sick. The second factor, as I mentioned earlier, is the Bronx is racially diverse, and it's well documented that Black and brown people are faring worse, both during the pandemic and with many health illnesses and with many health outcomes. But that was clearly true for the Bronx in this pandemic. Thirdly, there's a high percentage of people who are considered rent burdened who live in the Bronx, and that means they pay more than 30% of their income on rent, which is one indicator of a family's financial fragility, and thus make them susceptible to all of the poor health outcomes that are related to poverty. And lastly, this map is a little harder to see, but if you look at the colors of the heat map and not the dots, this is shows the disproportionate number of residents in the Bronx who live in overcrowded housing. And overcrowding has been associated with worse mental and physical health outcomes even before the pandemic. And again, it makes sense that with COVID, the overcrowding likely contributed to transmission of disease because of the difficulty of social distancing, quarantining, and isolating those in the household who were sick. So I'm going to tell you about the care that we provided here at the Montefiore Medical Center, which is part of the Montefiore Health System, which is an integrated health system of 11 hospitals. The Montefiore Medical Center provides care to the communities in the Bronx and the surrounding neighborhoods. We have 3 campuses. And CHAM, the Children's Hospital at Montefiore, is located on the largest of those 3 campuses, the Moses campus. Specifically, the Children's Hospital at Montefiore, we're a 140-bed quaternary care children's hospital. We have 26 PICU beds, 114 med-surg beds, which are spread over 3 floors, about 9,000 discharges per year, and about 50,000 kids come through our pediatric emergency department every year. As I said, we're on the Moses Division campus, so we share labs, radiology, pharmacy, and electronic medical record with the adult hospital. And we do at CHAM have a long-standing quality improvement culture, which I'm going to talk a little bit about later because it was relevant to our response. So as I said, we started to identify cases of COVID in New York City in early March. And as the month progressed, the number of hospitalized patients with COVID-19 in our system went from 7 to 700 in about 2 weeks. The hospitals were becoming overwhelmed, and it was clear that that trajectory was going to continue to increase. So the system started to think about ways that we could increase our capacity. Plans were made to deploy staff and utilize all physical spaces in the hospital to provide care. Initially, when we thought about it, we planned for a surge in the pediatric patients in the emergency department. We had in mind what had happened about 10 years ago with the H1n1 Flu Epidemic, when we really saw a real onslaught of pediatric patients seeking care. So we, despite the fact that the reports out of China indicated that children were not getting severe disease, we did brace for this sort of onslaught of worried well or worried well enough to come into the emergency room and into the hospital. Ironically, though, CHAM saw a dramatic drop in the number of children who required hospitalization. You can see that's the blue line here with the numbers on the right-hand axis. So we tried a few things to try to respond to the growing crisis. Consistent with recommendations from the Children's Health Association and others, we talked to our neighboring hospitals and we started to regionalize pediatric care, meaning that several of the local hospitals with smaller pediatric services closed so that their pediatric beds could accommodate more adult beds. And they brought the children to us, really, but that didn't make a big difference in our overall census. We also expanded our definition of pediatrics to age 30, meaning that anybody who came into the hospital who was 30 and under would come through the pediatric emergency room and get admitted to our pediatric services. But again, that really didn't make much of a dent in our overall census and our ability to respond to the pandemic. So essentially, we had a functioning healthcare facility, which was the Children's Hospital, a capable workforce, which was our pediatric staff, without a lot of patients to care for, in the setting of an overwhelming need to increase capacity for adult patients. So there are really two options of how to reallocate pediatric providers and nurses to care for adults during a pandemic. And this was actually discussed in a perspectives piece by Wolf and colleagues in the April 2020 issue of Pediatrics. In that perspectives piece, they were talking particularly about expanding pediatric ICU capacity, but the concepts are really the same. So first, the Children's Hospital can export resources, which would mean deploying providers to be integrated into healthcare teams led or run by the adult medicine providers. This can be done in a variety of ways, but requires the pediatricians and the nurses to work in different environments with alternative team structures and to learn new practice routines, a new practice environment, and a new culture of care. The alternative approach is for the patients to be imported to us. The pediatric team structure can be maintained. Pediatricians could lead teams of pediatric house staff and collaborate with pediatric nurses in our pediatric hospital. The adult patients could come to us. And this latter approach, we realized, would allow us to work with the team we were accustomed to working with, to keep our practice routines, to preserve our culture of care in the way we like to provide care in a pediatric setting. So obviously the idea of surging in healthcare is not a new concept. After Hurricane Katrina devastated the Gulf Coast in 2005, the Joint Commission published this report on providing safe care in emergencies. They said that healthcare systems have to be able to increase their surge capacity or the ability to quickly expand beyond normal services to meet the increased demand for medical care in an emergency. In natural disaster situations, they talked about establishing temporary hospitals at athletic arenas or other places when existing healthcare facilities were damaged. But when we surge in place, that's expanding the surge capacity of the already functioning healthcare facility. We go beyond standard operating capacity to meet the demand for care. We stay in our own environment, but we do things differently. So the literature on how to surge in pediatrics is actually quite limited. We found this one report from 2009 that was done on behalf of the AHRQ, which describes the recommendations for increasing surge capacity of pediatric hospitals to respond to large numbers of critically ill pediatric patients. It talks about staffing, supplies, triage procedures, things that you would normally expect to see, and many of the things we were doing already across our system. It also talks about the unique challenges in pediatrics and highlights that hospitals who care for adult patients should have adequate supplies to treat pediatric patients, as well as a plan to surge their pediatric staff if necessary. So like other children's hospitals, we do have emergency preparedness teams, and we do practice drills about what to do in the event that there were a large number of pediatric victims or pediatric patients. But what this report from AHRQ did not address, and we had not previously practiced, was what to do when we did not have the pediatric patients, but instead that there were adult patients who needed our beds and our medical care. So when we found ourselves in this situation in March, we needed to figure out how to respond quickly. Given the rapidly changing situation, the sense of uncertainty, and the general sense of fear of the unknown, given that everything was changing, The decision was made that we would stay in CHAM and we would surge in place. We would adapt our system to meet the demand for treating patients with COVID-19 and expand our staff's ability to care for adult patients in the Children's Hospital. So given the pace at which the situation was worsening, we had little time. The governor had announced in the middle of the week that there was an immediate need to double the bed capacity across the city. Our 3 adult emergency departments that comprise the Montefiore Medical Center had increasing numbers of patients waiting in the EDs for admission. On many days, there were upwards of 150 patients in each ED waiting. So the decision was made on Friday afternoon to open an adult COVID unit in the Children's Hospital on the following Monday morning. Because of the low pediatric census, we had fortunately already combined 2 units into one the night before, so we did have an empty floor. Over the course of the weekend, we created the unit. It required a high level of coordination between physician and nursing leadership, as well as individual preparation by each discipline and multiple other disciplines, including pharmacy, respiratory therapy, and others. We figured out enough of our plan over those first 48 to 72 hours to be able to open up on that Monday morning, but other elements did evolve over the first few days as we began to take care of patients. Key tasks for physicians initially included coordination with our adult colleagues, gathering protocols and medical information, and determining our staffing at the attending and resident level. Our nursing team readied the units with supplies, equipment, and staffing. Other key disciplines were the pharmacists who needed to expand the medications on the floors, the environmental team who needed to clean and prep the rooms, and the central supply team who traded out the supplies for pediatric patients in order to make room for the adults. And in thinking about how we were able to do this in such a short period of time and how we created this unit over the next days, I think there were really 3 critical elements, and I'm going to talk about each of them in a little bit of detail. The first was thinking about how we were going to structure the unit. And in determining how we would structure the unit, initially we thought about organizing a split unit with one end of the floor being floor beds for the relatively stable patients, and the other end would be a step-down unit for the relatively sicker patients. It quickly became apparent, though, that really the imperative was for us to create as many beds as possible with as much flexibility as possible. And we realized, based on what we were seeing on the adult side, that it was going to be difficult to assess who were the relatively stable and who were the sicker patients because their conditions could change so rapidly. So we created one single 40-bedded unit where we would care for adult patients at whatever level of care they required, as long as they did not require ICU level care. And at that point, the ICUs were so busy that the only patients that were able to get into the ICUs were patients that were intubated and ventilated. So we decided to divide into 3 teams of physicians to staff the 40 beds. Each was comprised of 13 or 14 patients. 2 teams were the responsibility of our Division of Hospital Medicine, who, although we were not expert in the care of acutely seriously ill adults, we were accustomed to the unit. We knew the physical environment really well. We knew how to do inpatient medicine, and we understood the workflows, and we were very comfortable with the nursing staff. The 3rd team was covered by our cardiology division, who also were somewhat accustomed to the environment and the staff on the unit. And in addition, they had the advantage of having the expertise and the comfort level of taking care of critically ill patients, although not adults. Because we were adding teams and also 24/7 overnight coverage, we did need to expand our pool of providers even beyond those 2 groups. Faculty from other divisions were identified who would be comfortable enough caring for acutely ill hospitalized patients. So in general, these were attendings from specialties that provide a lot of inpatient care, like oncology and gastroenterology, or individual faculty who were relatively young so that their residency training was not too distant of a memory. And then because the state of emergency had been declared in New York State, we were able to obtain emergency attendant credentials for some of our senior fellows. So in the end, we had about 15 attendings from 9 different divisions, in addition to our hospital medicine and cardiology teams, and 4 fellows who were granted attending privileges help us care for patients on this unit. And then obviously, in addition, each team required residents, PAs, We had fellows and volunteer medical students who are also acting as frontline providers. In addition to the direct medical care providers, our palliative care team was significantly expanded to provide extensive support to patients and their families. We had in-house palliative care consultations for patients who were facing decisions regarding advanced care directive preferences and those who needed some help in making those decisions. In general, though, mostly the team provided telephone-based services. There was a team of supportive callers who called the patients and their families to check in, to reassure, to answer general questions. And this team was particularly important because at the time we had no visitors allowed. In the beginning of the pandemic, family members were not allowed in at all. We also had a team who were the bereavement callers who called the families starting within 24 hours of a patient's death and continued to support the family for approximately 3 weeks. In the presence of the palliative care services provided solace and support not only to the patients and families, but really provided solace and support to us as the direct care providers as well. This was a time that not only were we not allowed to have family visitors, we were discouraged from spending a lot of time in the room. It was very early in the pandemic. We didn't really know enough about how it was transmitted. Everybody was worried about PPE shortages. So providers did not spend a lot of time in the patient's room sitting and talking and getting to know our patients as we were used to doing. So through the support of callers' notes, we learned a little bit more about the patients and their families and felt a little bit more of that human connection that was so important. The palliative care also provided scripts and guidance to us as the providers on how to obtain healthcare proxy and advance directives early in every admission. Again, a practice that we were not in the habit of doing and a skill we had not really developed. So as soon as we decided we were going to create the unit, we also reached out to the leadership of the Adult Hospital Medicine Division in the Department of Internal Medicine. We knew that their help would be absolutely critical for us to be able to take care of patients. So our adult colleagues, fortunately, had recognized the same as they were providing support across the system to providers who were not normally taking care of hospitalized patients. So they developed what they called their Hospitalist Advisors. For the first 3 days that we had patients on the unit, they were on site with us. They helped us adapt our workflows to mimic the care they were providing for patients with COVID. They helped us how to figure out how to identify who were the really sickest patients, because when they all came onto the floor, they all looked pretty sick to us. They gave us a crash course on the management of common adult chronic conditions, particularly diabetes, hypertension, and they brought us donuts each morning. After the first few days, they made twice daily visits to the unit, and then they were available by phone 24/7. In addition, we had the help and support of the Popcorn Network. For those who are pediatric hospitalists, you may have heard of the Popcorn Network. This was a network created by MedPeds hospitalists at Cincinnati Children's and some other places. And they made themselves available, again, 24/7 to provide telephone consultation about any questions we had about managing chronic illness or managing illness in adults. And they were also incredibly helpful. So as we were thinking about how to structure the unit, we also needed to think about how to identify appropriate patients for our unit so that we would be able to function relatively independently. So we agreed that we would not screen patients based on the severity of their COVID symptoms, again, as long as they were not intubated and requiring ICU level care. But we did think that it was appropriate for us to try to limit the number of comorbidities patients had, since we were not expert in taking care of adult chronic illness. We figured we could learn one illness, which was COVID, but to try to learn all of adult medicine in a weekend didn't seem to make a lot of sense. So we wrote these screening guidelines as a sort of first pass for patients to be admitted to the unit. And there were that COVID had to be the primary diagnosis. The patient needed to be being admitted for acute COVID disease. We initially said we wanted to keep to patients under the age of 50 because we thought they would have fewer comorbidities. And then also a explicit attempt to look at the comorbidities the patient had and to limit them to no more than 2 major organ dysfunctions. And really Diabetes, hypertension were not counted as major organ dysfunctions because so many of our patients had that as underlying illnesses. Screening the patients proved easier said than done. Given the volume of patients in the emergency department physicians really didn't have the time or the ability to talk to us about the patients before they were admitted. So we set up a system through our admitting office to try to work with them to screen patients. They also were under extraordinary pressure to assign available beds and not to hold patients in the ED for any longer than they needed to. So we needed to figure out a system that would be quick. So what we did is when the patient was targeted for our floor, they called our charge nurse. The charge nurse took a quick look in the chart and used these screening guidelines. If the patient did not meet criteria, the charge nurse called down to admitting and asked them to put a hold on the bed for 10 minutes while an attending could immediately do a more in-depth chart review to determine appropriateness for the floor. This actually worked reasonably well, and over the course of the time that the unit was open, we became more accustomed to taking care of the adult patients. We did not restrict to patients under 50, and in fact, our oldest patient was 88 years old. And we became a little bit more comfortable with taking care of patients with increasingly complicated comorbidities, so that screening criteria sort of changed a little bit as well. The second key consideration in how we transformed the unit was really a reliance on rapid cycle learning. And this is where our strong foundation in quality improvement work came into play. Many people in our system were already familiar with the concept of rapid cycle learning and doing short PDSA cycles. Over the previous month, our environment, our knowledge, the patient population were all changing and evolving so quickly that we had already been making changes, adapting, and disseminating information quickly on an essentially daily basis. So a couple examples of some ways in which rapid cycle learning helped us. As I said, there were near daily institutional changes and involving guidance about practices, decisions about who to test for COVID, how to define a PUI or a person under investigation was evolving as we learned to better recognize symptoms as the prevalence of the virus increased and as testing became more available. And again, we're all very used to this now, but back in March of 2020, this was all very new to us. So with that, our isolation policies had to change nearly daily as we better understood the risks for transmission. And as we understood the risks for transmission, and we were also had ever sort of evolving concerns about availability of PPE, the guidance about PPE use and reuse was changing daily as well. Although there was some experience in managing patients in China and in Europe, relatively little was known about how to care for patients medically with severe COVID disease. So practice guidelines also changed frequently regarding anticoagulation, steroids, antibiotics, antivirals. We tried to keep abreast of current literature on, well, not literature, but the websites, listservs. There was very little literature at the time. We borrowed from other institutions. We learned while we practiced, and we tried to study our data in real time. There were many best practices that evolved and had to be adapted. So for example, on a very local level, the guidance changed so that they recommended that we minimize the use of nebulizers because nebulizers created aerosolized particles, which could spread the virus. So we switched from using nebulizers for albuterol treatments to nearly exclusive use of MDIs within a matter of about 24 hours or 48 hours. Under normal circumstances, this kind of big change in practice probably would have required months and many PDSA cycles, but because we were in the mode of rapid cycle change, everybody was able to adapt. So to accomplish this change and adaptation, we had over the previous weeks really increased communication via meetings, daily briefs and huddles. People were sending regular emails, particularly from the leadership, to keep everybody informed. And information was disseminated very quickly. We created a web-based team site so that protocols and guidance could be all posted in the same place so that we didn't get confused with multiple versions of documents coming out over short periods of time. So the rapid cycle learning was not limited to learning medicine and medical protocols. There were other things that we needed to learn to meet our new challenges. Clinically, we needed to learn how to recognize and treat adults and their medical concerns, how to ease their anxiety when we were feeling anxious. We needed to learn how to communicate with patients differently and have our patient interactions differently. First of all, we had to communicate with families by phone. The families, as I said, were not allowed in the building. And as pediatricians, we're used to the families being right there at the bedside. So that took some getting used to about how to really effectively communicate, particularly when it was bad news by phone. We also, and again, now we're all used to this, but in March of 2020, this was quite new, figuring out how to communicate with literal barriers between us and the patients with our face masks and our masks and our face shields and our gowns and our gloves. Took some getting used to really feel like we were connecting with patients and being heard. The other thing that we really needed to learn is we needed to learn how to take care of ourselves and accept uncertainty. Uncertainty about what would come next, about how our patients would fare. And we needed to learn how to leave it at work a little bit and not take it home every night so that we could get some sleep and rest. And this all took learning. And that learning was facilitated by, again, leadership was sending daily emails and other updates. We tried to have at least twice weekly meetings of the providers at the multiple levels to stay connected. And importantly, we really tried to stay connected through eating together, sharing downtime together. We had several respite rooms set up where there was food and other relaxation things, coloring books, other sort of the fidget toys and stuff like that for people to really have a chance to relax and share the experience together. Of course, now we're not allowed to eat together, but in March we were. The third element that really enabled us to be successful was an explicit attempt to really maintain and think about our systems of communication. And I have to say, this as though it seems pretty self-evident, it took a little bit of time for us to realize the importance of some of this stuff and to maintain our systems of communication that we were comfortable with. And a couple examples of that. The first time that we needed to intubate a critically ill patient on the unit, we realized that we had not come up with a streamlined process for escalation and communication. We needed the expertise of the adult rapid response team, but they were about 5 minutes away on the other side of the hospital. So we also wanted the rapidity of response that we could get from our pediatric rapid response team, which was right upstairs. Once the patient was intubated and waiting on the floor for the ICU bed to be ready, we needed providers who were comfortable with vent and ICU management to be available to care for the patient while we waited. And ultimately, care escalation became a collaborative effort between the pediatric rapid response team from our pediatric ICU, the adult rapid response team from the critical care service on the adult side, and our floor-based hospitalist, cardiologists, nurses, with everybody having well-defined roles, but it did take explicit clarification and discussion. A second way in which we thought about our structure of communication was in calling consults. Early on, our department agreed that for consultations to subspecialists, we would call our pediatric colleagues and they would decide whether or not they needed to confer with their adult counterparts. This minimized the need to further burden the already overburdened adult subspecialists and also enabled us to continue to work with colleagues who were familiar to us. When there were times that the pediatric approach differed from the adult approach, we could also consider using the adult protocols with the guidance of our adult the Hospitalist Advisors, so that we did not need to reach out directly to the adult subspecialists very often at all. And then a third way in which we maintained communication was within the teams itself. For the first days, we actually skipped. Previously we had a 7:45 huddle on the floor every single morning. And for the first couple of days, we skipped that huddle because we were distracted, we were busy, all of our routines were new, and we were getting used to the new patient care. But we quickly realized that we should and could maintain our normal workflows. Even if the patients were different, our communications should be similar. So rather than being an interruption, we realized the morning brief was essential to maintaining our situational awareness and our teamwork between the physician, nurses, and other people on the floor. So how did we do? Over 3.5 weeks, from March 30th through April 23rd, we cared for 147 adults with COVID in our pediatric hospital. And in order to describe the demographics and to give you some context for our outcomes, I just want to also compare to these 3 other studies that were available at approximately the same time. And I know now there are many more studies with more detail and more results, but I'm comparing to these because these are the ones that were available and represent results from early in the pandemic as our unit's results do, so relatively comparable. The first study was published as a research letter in JAMA. It describes 377 hospitalized patients there in Northern California through the Kaiser Permanente system. It's a retrospective cohort study of adults hospitalized at one of 21 hospitals during their month of March. The second study was done at Northwell Health, which is here in New York City, on the border of New York City and Long Island. They described 5,700 patients of all ages who were hospitalized in their 12 hospital system between March 1st and April 4th of 2020. 44% had outcomes at the time that their study was published. In the California study, 85% of the patients had outcomes at the time of the publication. And then the China study was out of the 2 of the largest hospitals in China who cared for patients with COVID-19 at that point. It included 191 patients, and all of their outcomes were reported at the time of their publication. So here are the demographics for our 147 patients that we saw at CHAM. As I said, we initially certainly tried to capture a younger population of patients. So the median age of our patients was 47 years, with an interquartile range of 39 to 56 years. But as I said, our oldest patient was in his late 80s. The vast majority of our patients were male. 1/3 of the patients were Black or African American, 44% were Hispanic, and about 1/4 of the patients spoke a language other than English, with Spanish being the majority of those patients' language at home. Here are the other programs. And again, when comparing our cohort to the other cohorts described, remember that each study collected and analyzed their data a little bit differently. And again, we did have a biased sample of quote unquote healthier patients, so that really this is not comparing apples to apples. And I only report the percentages for the non-children's CHAM studies, just to give a general idea of how our population of patients compared to others. And you can see the results there. In terms of other demographic characteristics, compared to the cohort at Northwell, we had a higher percentage of Black patients, Hispanic patients, and those who were not primarily English speaking. This is a reflection of the demographics of the population served by those 2 hospitals. And the other studies really did not describe the demographics of their study population in a lot of detail, so I don't have information about that. Looking at the clinical characteristics and the comorbidities, as I said, it was our intention to limit the number of pre-existing comorbidities of the patients admitted to CHAM. So for this, we looked at comorbidities that were presumed to be most associated with poor outcomes based on the limited prior literature that we had at the time, including obesity, hypertension, diabetes, heart disease, and respiratory disease. Half of our patients had 1 or fewer comorbidities, with obesity and hypertension being the most common. On the bottom half of the slide, you see the Charleston Comorbidity Index. This is a measure of total comorbidity burden. It predicts the 10-year mortality based for an individual patient based on their age and the number of serious comorbid conditions. It's pulled from ICD-10 codes that exist in the electronic medical record and was calculated as part of our data extraction when we pulled these data from our electronic medical record. The lowest score is 0 and corresponds to an estimated 98% 10-year survival rate. So the fact that over half of our patients had a score of 0, again, reflects the fact that we selected for patients in general that were younger and had fewer comorbidities. Comparing to the other studies, the rate of obesity was similar to that reported at Northwell. The rates of obesity are not available for the other 2 sites. And then you can see hypertension and diabetes were the 2 most common comorbidities reported in all 4 of the studies. While we tried to limit existing preconditions and comorbidities, as I said before, we did not limit disease severity due to the COVID-19, except for the patients who were already requiring critical care while they were in the emergency department. So again, looking at the CHAM numbers overall, patients were pretty hypoxic on arrival to the emergency department. They had a median O2 sat of 91%. 57% of patients required nasal cannula on admission, and that ranged from a few liters to 6 to 10 liters per minute. Ultimately, during their time on the floor, 1/4 of patients required non-rebreather at 100% oxygen, often for many days. 4% of our patients were put on high-flow nasal cannula, and this number really reflects the limitation of our equipment availability at the time, not necessarily the severity of illness. And 16 patients, or almost 11%, required mechanical ventilation. And again, all the patients did remain on the floor until intubated and requiring mechanical ventilation. So the total of the 16 patients who required mechanical ventilation were all emergently intubated on the unit and transferred either to the pediatric ICU or an adult ICU, depending on bed availability. 1 patient did die shortly after being intubated on the unit, so was not transferred. 6 patients required dialysis, which was done either on our unit or in the ICU, depending on the patient's respiratory status. Comparing to the other studies, again, to remind you that we don't know, that it's not really comparing apples to apples. We don't have a lot of information on what the other hospitals used for criteria of who got ICU level care versus who stayed on the floor, so that could be very different. Also, our population, again, confounded by the selection bias, particularly age. But you can see that our proportion of patients who required ventilation and ICU admission were similar to what was seen in Northwell, much less than what was seen in the California study, and somewhat less also compared to the China study. Okay, so final disposition of our patients. Of the 147 patients, 91% were discharged and 9% or 13 patients died. Of the 13 who died, 4 died on the unit and 9 died after transfer to the ICU. Of the 4 that died on the unit, 3 had DNR orders in place, and the other was the one I mentioned who died immediately after intubation. The overall length of stay on the unit was 4 days with an interquartile range of 2 to 9 days. So some patients did have a pretty short length of stay, but we did have several patients who stayed for many weeks. Looking at our overall mortality, it is less than these other studies, though in general, again, hard to compare because we had an intentionally biased sample and not all of the outcomes were reported for all of the patients in the cohorts because many of them are still admitted when the publications were printed. But as I said, we targeted healthier patients. So we would expect that our mortality rate would be the same, if not lower, in the Children's Hospital at Montefiore compared to the rest of the Montefiore health system, which at the time, the mortality rate across this health system was about 20%. So fortunately, we've come a far way in our ability to provide care to patients with COVID-19. We've learned a lot about the disease, how to manage it, and our mortality at our institution and across the country is much lower than these initial numbers indicated. So to sort of wrap it up, why did this work? First, because we worked with familiar teams and in our familiar environment. And because we had so little time to do this, having one less thing to worry about was really critical. Our foundations and quality improvement really allowed us to quickly adopt the methods of continuous learning and ongoing performance improvement. We did stretch our capabilities, but we recognized our limits and we knew when to get help and how to get help when we needed it. And really in March of 2020 and into April, there was an amazing sense of community support and camaraderie. People really knew that we were being asked and that this was an extraordinary period, and people really came together and rallied and did whatever they needed to do in a way that was really amazing to see. So fast forwarding to February of 2021, unfortunately, as we all know, case rates and hospitalizations are still high across the country. Fortunately, case mortality rate is much lower. And I think that hospital systems, and including Montefiore, we're facing different challenges than we did last spring. In the spring, there was really a complete shutdown of any other hospital business here, for better and for worse. Ambulatory visits were canceled, elective surgeries were canceled. Patients didn't want to come to the hospital because they were afraid of getting sick, with getting infected with COVID. So our non-COVID business really is virtually shut down so that all resources that we had could be focused on taking care of the patients with COVID when we needed to do that. But now we're faced with a variety of needs and the need to balance them. So now we have patients with COVID, although fortunately fewer than we did in the spring, about 1/3 the COVID inpatient census that we did have. But we're also conducting business as usual. We're continuing to do elective surgeries. Ambulatory visits are continuing. Patients are coming into the hospital for their regular care, which is good because we want patients to get the care that they need. But it's leading us to think differently about how we're using resources. Before all of the person power, all the providers were available to help take care of COVID patients. Now they're busy doing their regular work. Space is at a premium because we have the high volume of patients, but we need to be thinking about how to keep patients socially distanced, keeping the COVID patients separate from the non-COVID patients, and all of the challenges that new physical distancing brings is something that we're working on. And I think that in addition, there really is a sense of weariness that there was not in the spring among providers and staff, as what we had hoped was going to be a short sprint has really turned into a long haul. And the continued sense of the need to address these ongoing considerations is a challenge that we're continuing to face. That is fortunately counterbalanced by the arrival of vaccines and the fact that people are getting vaccinated. So there's a light at the end of the tunnel. And we will continue to use the tools that we used in the spring to adapt in real time to meet the needs of our patients, the needs of the hospital, and the needs in our community. So before I end, I just want to acknowledge a few people. I want to thank my colleague, Dr. Caitlin Phillips, who did the data collection and the analysis of the outcomes. Dr. Phillips and Dr. Catherine O'Connor, who collaborated with me on an earlier version of this presentation. I do want to send a big thanks to the Division of Hospital Medicine and the whole Department of Pediatrics here, who, as I said, really rallied to make this possible. To our internal medicine hospitalist colleagues who provided the support that we needed to help us take care of adults and learn adult medicine literally overnight. So I'm happy to take any questions people have. Thank you.
Thank you so much, Dr. Hammonds. This was just such an impressive story and such a lot of work and a very comprehensive approach with an enormous amount of challenges. It makes me realize how lucky we've been here in San Francisco with a relatively low burden, certainly not a huge burden for our children's hospital. There's a whole bunch of questions. So I'm going to see how far we get in the 10 minutes or so that we have left. The first question is about advanced cardiac life support. Did you retrain your pediatric residents, fellows, faculty in ACLS?
So great question. We really did not have time to do that. We once we got started, we did try to have some real-time sessions for the residents and for the faculty as we could, but we relied more on our ICU folks to come down and help us with that, and with our adult colleagues, because there just literally was not time to do that.
The next question is, you mentioned high flow nasal and intubated patients requiring mechanical ventilation. Did you utilize non-invasive medical ventilation like CPAP or BiPAP with any frequency?
We did not on the floor. Some patients, when they were extubated, wound up being put on BiPAP, and really it was because of a limitation of the machines. That the CPAP and BiPAP machines were repurposed to be used for ventilators. So, and the other part, and I find this interesting, having come from a different institutions like different machines, and we are a high flow institution as opposed to a CPAP institution.
Yeah, I as an intensivist, I can relate to that. We went from BiPAP, CPAP to high flow, and now we're a little bit of both finally again. But
Right,
yeah,
right. No, we're still high flow.
The next question is from Dr. Peter Miller, a public health pediatrician, and he's interested in hearing how did you handle the lack of protective equipment, any controversies over treatments, and lack of efforts to prevent disease onset, things like masks, distancing. Like, I think the question is mostly like, how did you handle the lack of PPE and any controversies around what works and doesn't work?
So it's a great question. You know, it's just thinking back to the details, we never completely ran out of PPE. We did reuse a lot of PPE, and that was where the guidance changed as they realized that there was concerns that we were going to have shortages. We thought about what were the best strategies for reusing PPE. So early on, immediately as we started to see that we were starting to surge and that PPE was going to be a consideration, we immediately stopped doing family-centered rounds. So I'm trying to think exactly when, like the first week in March, when we saw what was starting to happen, we stopped doing family-centered rounds so that we wouldn't have to use the gowns and the gloves and gown up the medical students and the residents and the whole team for every patient. And then we started to talk about how to reuse N95s, how to make sure that you kept them covered, kept them clean, how long you could reuse them for. Face shields, we had special protocols for how to wipe them down after every use, so that when we donned and doffed, so we would do as little contamination of our equipment as possible so that we could reuse equipment. We never got to the point that we had to decide which providers got PPE and which did not, to be honest, which was fortunate. I think we made the conscious decision that if we were going to try to limit as much as possible the PPE that we used, and if someone didn't have PPE, they did not take care of patients. So we made sure that the people who had to go into the rooms had the appropriate PPE, reused or not. So does that answer the question?
I think it does. I have a follow-up question on it, and that's, did you transfer rounds, but you said you stopped family-centered rounds, did you transfer all or part of that to a web-based platform, or how did rounds get done? So
we wound up having rounds outside of the rooms. We sat down, we went through all the patients, and then a small group of usually the attending and one of the residents went in to see the patients. And we had kind of a rotation that some members of the team went in the morning, some members of the team went in the afternoon, so that we all got into the room, but not in a big group. And we tried to have a system whereby we spread it out so that we could see the patients as often as we needed to, but with as little exposure as possible.
Got it. Next question says, thank you so much for sharing. How were you able to create and disseminate the new workflows and protocols to team members so quickly, especially across teams who typically never worked together before?
Yeah. So what we did is we had the adult hospitalists come over and they sat with us, and we literally, the first patients were scheduled to come up at 10 a.m. So they came in at 7 a.m. From 7 a.m. to 10 a.m. They sat with us and they said, okay, this is what our patient flow looks like. This is how we do our rounds. This is how we see patients. And we had a small group of hospitalists and cardiologists who covered for those first few days until they got very comfortable with the routines. We had a day shift and a night shift. And then as they were getting ready to hand it off to the next group, they did a Zoom presentation, and they went over everything with their workflows, and we had it written as sort of a protocol, which we then presented on that Zoom link. We taped that Zoom link so that as future people rotated onto the service, they could watch the Zoom link, and we had the protocols written down. And we made sure that as people came on who had not covered the service, we had one of our senior hospitalists give them an orientation and really go through the workflows with them. So we really just kind of did it iteratively in real time.
In real time, just in time. Another question is about your rapidly scaling up of palliative care services. How were you able to achieve that? And has it had a lasting impact on the culture of the pediatric hospital now that things are back to normal?
Yeah. So how we were able to achieve that is our palliative care specialist, Dr. Sarah Norris, identified 2 senior fellows who she had been working with to help her sort of organize the structure of the team. And then we used folks who, for whatever reason, had medical conditions or other reasons why they could not take care of patients but wanted to help, but they couldn't do things in person. And so they became the teams who Dr. Norris worked with, provided scripts, and provided, again, real-time trainings on what those support callers would look like. And then the bereavement callers was a group within that of people who had had some experience in the past working with bereaved families. So again, really picking and choosing who we're going to be as part of that group. Has it had a lasting impact? I think so. Yes. And we are now again back to having adult patients in our children's hospitals, a much smaller volume and much less hectic, but we are much more comfortable now with the getting the advance directives and asking for health proxies for the adults. It's a little bit different in terms of the supportive calls because we now allow visitors and we are less afraid to spend so much time in the room because now we know PPE works and we're all vaccinated. In terms of a change in culture overall, it's a good question. I would say anecdotally, I think that we're better at asking our 18 and above patients about advanced directives and healthcare, not advanced directives, but more healthcare proxies. But I think fortunately, we've really been able to go back to having the ability to support patients in person that we didn't have then, and the palliative care services filled such a gap in the spring.
We're out of time, but I'm hoping that I can ask one more question and hopefully you can give it a concise answer, although it's not an easy question.
Do my best.
3 questions. I'm going to put them in one because they ask about the same thing. It's the collaboration, communication with the Department of Public Health and other city and state groups, and what attention there was for racial equity, social justice in coordinating the care.
That is not a short answer, but I will. So coordination with really, there was such an onslaught of patients that there was not really an opportunity to think about where patients were being cared for. Every hospital really took care of the patients that came to them. Interestingly, on our adult side, they did take a look at issues around disparity, and it was clear that many more patients particularly, if I remember correctly, and I don't want to misquote the study, but I'm pretty sure they looked specifically at patients who identified as Black or African American, and there was a much higher percentage of them compared to non-Black patients that got admitted. But once they got admitted, their mortality was not significantly different. So we did try to look to see if where the source of the inequities were, and in again, a limited population, but within that cohort, it looked like once they got into the hospital, the care was reasonably the same. But obviously a much huger issue and could be its own talk or talks all by itself. Yeah. And I think, again, because it was just such a quick onslaught, we didn't have the opportunity to really set up systems in a way that, had we been able to be thoughtful, we might have.
Thank you so much for still giving a very concise answer to this complicated question. We're over time. Dr. Hirsch just sent me a quick message that he had to hop off, but is very grateful for this fantastic talk. Thank you so much for joining us, and for everyone who was able to attend. Thank you and have a good rest of your day.
Thank you so much. Take care.